Hello, everyone, and welcome back. Thank you for joining myself and my brother Rohit as we switch gears to now focus on hematologic malignancies for the next few episodes. This is very similar to our day to day community practice where we get to see it all: a patient with breast cancer, colon cancer, and in the next room, we have a patient with CLL.
Though CLL is the most common leukemia in adults, its trajectory has changed completely since the use of BTK inhibitors over past 10 years. We've also seen the use of BCL2 inhibitors such as venetoclax, which has taken a step further in prolonging survival in our patients. We are thrilled to have Dr. Nitin Jain from MD Anderson Cancer Center join us today, who has led a lot of work in this particular space of CLL treatment options. Nitin, thank you so much for joining us.
No, I'm delighted to be here and thanks for the kind invite.
Appreciate it. Nathan, we acknowledge that not everyone needs treatment in patients who have CLL, especially when we talk about even TP53 or 17p deletion, especially when they have slow doubling time or they're rather asymptomatic. So the question is, how do you personally define a patient who needs treatment versus who does not need treatment?
Yeah, so I think in this regard, so International Workshop for CLL or IWCLL, which is a global organization of the CLL colleagues. So they have over the many years have established guidelines to basically which patients to treat, so which are called IWCLL treatment criteria or treatment indications basically. And they have also the response assessments and all those things we do in clinical trials. So the last version of IWCLL was updated in 2018. It was a paper in Blood by Dr. Professor Halleck. So that is basically what sets the paradigm, and practically all clinical trials use that to indicate when a patient would need treatment. So these are the guidelines. There are multiple,
Right.
multiple criteria, but I think from a clinical practice and for your audience, I think in my practice, the three most important ones. One is cytopenias, so hemoglobin less than 10, platelets less than 100, attributable to CLL. You have to make sure there's no autoimmune hemolytic anemia and things like that. Second is significant adenopathy, so significant or progressive adenopathy. And the guidelines list more than 10 centimeter. I personally think if it's growing and it's above 5 centimeter, I think is reasonable to think about starting treatment. And the third is significant symptoms attributable to the disease. Affecting quality of life, so that sometimes can be a bit challenging. What is significant symptoms? But I think if they're in combination with cytopenias or some cytopenias and adenopathy, and patients also having some worsening symptoms, that certainly meets the criteria. So I think those criteria are kind of established, so they're written in the in a paper. So I think I would say those are the patients who should, if they do not meet those criteria, then we should be observing those patients. And I think if you diagnose a patient with CLL, I would say 90% of patients will be placed on clinical observation or watch and wait approach because they will not be meeting those criteria. Very few patients meet that criteria requiring treatment practically within a month of their diagnosis of CLL.
Thanks for covering that. And now, once you have actually, in fact, decided this patient does need treatment, whether that's based on the symptoms, cytopenias, or doubling time of the white blood cell count, what does your minimal workup looks like in terms of scans, bone marrow biopsies? What are we exactly looking at?
Yeah, so you raised an important point of the lymphocyte doubling time, and it's also on the slide here. So maybe I should comment on that briefly as well. So I think, in the slide here, I would say observation is for patients not meeting the IWCLL treatment criteria. Rise stage and Binet stage doesn't per se identify patients who would not need treatment. For example, a patient with Rise stage 0 CLL would be someone who has a white count of, let's suppose, 25,000, majority lymphocytes, normal hemoglobin, normal platelets, normal lymph nodes, but could be significantly symptomatic from the disease. It's a rare scenario, but occasionally we have a patient like that and who would need treatment. Same thing for Rise stage 1, patients who have lymph node-based disease, certainly a common indication that we need treatment. So I think observation is not based on Rai or Binet stage, it's based on the IWCLL treatment criteria. Now, lymphocyte doubling time is one of the criteria that if it's less than 6 months, then we should start thinking about treatment, or if it's more than 6 months, continue to observe. I would say that in clinical practice could be a bit tricky because there's a difference on a lymphocyte doubling time from 100,000 to 200,000 versus a lymphocyte doubling from 15,000 to 30,000. The magnitude is different, right? So sometimes I see in clinic being referred where someone is trying to start a treatment when the white count has gone from 15 to 30, which I don't think we should be doing that. So I think there's some nuance involved here. But yeah, I mean, I think but that is certainly someone who has a lymphocyte doubling count of less than 6 months. I'll be watching more carefully. I generally don't start just on the basis of that unless the white count has become very, very high. And you asked about the treatment, the minimal, workup.
Yep.
So one thing I think important from a clinical standpoint is that for practically most patients with CLL, you can diagnose them on the basis of blood, peripheral blood. You don't need a bone marrow. You don't need a lymph biopsy. So most patients with CLL will have circulating lymphocytes. So you can send a peripheral blood flow cytometry, and for most patients, it will be clear cut for CLL. Now, there will be some patients where the pathologist or the flow may not be 100% concurrent with CLL. There will be some atypical markers, and some of those patients could be mantle cell or splenic marginal zone lymphoma, and you may have to do a bone marrow or a lymph node. But for, I would say, 90% of the patients, it's straightforward. You can do it in the blood, and flow would confirm CLL. Now, once you diagnose CLL, there are prognostic markers which could be assessed. In my opinion, there are three important ones. FISH panel for CLL, which we can show deletion 13q, 17p, 11q, trisomy 12. Those are the markers we check. Then IGHV mutation, which is very, very important. And then TP53 mutation, which another is very important. So I think those three tests we do routinely for our patients.
Nitin, thank you for laying that foundation. You now have your peripheral flow, the FISH. Based on our available treatment options here, we have time-limited venetoclax or long-term BTK inhibitors. Given the basic information that you just collected, what is your treatment paradigm here?
Right. So I think it's important for people to realize that let's suppose you were to take 100 patients with CLL on day one, and if you ask a simple question, how much time does it take for an average patient to need treatment? That'll be about 5 to 6 years from the time of diagnosis to the time of treatment. But when that time of treatment comes, so I think the schema you have kind of outlined in the slide here. So I think, yes, P53 deletion 17p and or TP53 mutation is an important kind of a factor to know. And if, the current guidelines would suggest, and these may change down the line, but at least for now, if you have a deletion 17p or TP53 mutation, which is present maybe in about 10 to 15% of patients, so, for CLL needing treatment, then I think current recommendation would be to use a continuous BTK inhibitor therapy. Most data, or we are preferring these days second generation BTK inhibitors, which would include either Acalabrutinib or Zanabrutinib. Those are the two approved, FDA approved agents. And I think the slide here does list plus minus obinutuzumab, but really the data, actually for P53 subset, the data with Acalabrutinib for that group of patients, plus minus obinutuzumab did not add to the TP53 mutation subset or del17p subset. So I think for that one, I would say single agent BTK inhibitor, I think would be an appropriate option for that patient, such as either Acalabrutinib or Zanabrutinib. For patients without TP53 mutation or del17p, which is 85 to 90% of the patients, that's the big chunk of patients you'll be treating. IGHV mutation analysis can help us a bit. I would say it's I think in terms of the treatment choice, these days, the FCR is listed as a standard, as a therapy, potential therapy for mutated IGHV patients. I would say that in our practice, and I think practically most CLL doctors or hospitals have stopped using chemotherapy completely. So we have not used chemotherapy at our center, though FCR was built here as a regimen 20, 30 years ago by Dr. Michael Keating here. We have not used FCR for our patients for the last 3-4 years now. So I would personally not use FCR. And then really the option becomes either do a time-limited ven obinutuzumab, which is a 1-year therapy, or do a second generation BTK inhibitor with and without obinutuzumab, which really the data is with Acalabrutinib. We don't have the Zanabrutinib plus obinutuzumab data. And in that regard, I think, though who could argue that mutated patients venobin may be preferred, but I think, in my opinion, I personally don't make distinction based on IGHV status. I think even the unmutated patients can get venobinutuzumab, and yes, they will finish 1 year of therapy and they may relapse sooner, but at that time you could retreat them or do a BTK inhibitor in a second line therapy. So I personally make that decision between the two, Acala and Zanu, indefinite therapy versus venobin. I present both the options to the patients. And I think the really decision comes down to maybe the patient comorbidities and maybe patient's preference, right? So if a patient doesn't want to come to the center for tumor lysis monitoring and infusion reactions, or infusion and then subsequent potential reactions, more neutropenia with venobinutuzumab, then I think a BTK inhibitor therapy is much easier to initiate. On the flip side, patients, especially on the younger side, they want time-limited approaches. They feel they'll be done. I think venobinutuzumab is quite appropriate. So I do offer both the choices to the patients. Also the comorbidities. If I have a patient who has a recent heart attack, MI, stents, they're on anticoagulation, they have uncontrolled AFib, I'm just a bit more concerned about BTK inhibitor, and I may consider using venobinutuzumab as a more preferred approach, or at least I will tell the patient I would prefer that. On the flip side, if a patient has very bulky lymph nodes in the abdomen, 10 centimeter or higher, their creatinine is 2.5, GFR is 20-30 range, I'm just worried about tumor lysis with ven. And for that patient, I may maybe tell them more about a BTK approach, So I think those also factors, like the patient factors, plus also at the end of the day, patient choice. If all things being equal, I tell the patient both are good options, whatever you want to pick, I'm with you there. So I think those are kind of my strategy, I would say, outside of a clinical trial setting. Certainly I would say that clinical trial is preferred, but yes, and I think those are the things I kind of consider deciding on these treatment options.
Thank you so much, Nitin. There's quite a bit to grasp here. One, I would like to reiterate that there is no patient out there who would, really rather needs treatment with FCR anymore. Yes, I know there are some practices utilizing that, but one should switch that approach to now, whether it's time-limited versus non-time limited approach without utilizing FCR. Now, talking about venetoclax and obinutuzumab, we in community have had a low uptake because sometimes we talk about the supportive care we have available. How's your experience been, especially when you talk about the managing the side effects? We need a lot of hand holding for the patient's initial aspect of it.
Right. So you're correct. I think, the issue with ven, and I say sometimes that it's not that the TLS actually happens. It's just the logistics part of it. Most of the time, if you manage the patient, hydration and allopurinol, and if it's a high-risk tumor lysis patients, you admit the patient, but those are a small group of patients. Patient generally doesn't get tumor lysis, as long as you follow the recommendation. But the logistics of it can be challenging, especially I can understand, and I'm well aware of the issue with obinutuzumab. So I think in our practice, obviously, we do it quite often and quite routinely, so it's a bit more streamlined in our group. But yes, I tell the patients if I'm going to start venobinutuzumab, because you have to realize the first month is obin alone. So it's day 1, day 2, day 8, day 15 of obin. And then technically on day 22 of the cycle 1, you need to start ven at 20 milligram. And then ven goes weekly dose escalation for another, 5 weeks. So I tell the patients that for the first 2 months, you're coming to Anderson once a week. And some of those visits could be 2 consecutive days, depending on next day tumor lysis labs on day 24 hours later. But once you are done with weekly visits for 8 weeks to say, then it becomes much easier, because then, most of the time the visits are much less and they're just once a month infusions, and venetoclax is, 400 milligrams daily continuous dosing. And So I do tell them that there is initial involvement, but then later it's much easier, and it's a time limited approach, and you don't have to deal with potential BTK side effects, which can sometimes be significant, especially for older patients who may have some cardiac comorbidities. So I would say in our practice, with our clinic team, my physician assistant, when we start Venobin as standard of care, so we have a system in place. We tell the patients, what to expect. Most patients will have an infusion reaction to obinutuzumab on day one. So I prime them that that's what's going to expect. I tell them about venetoclax, that neutropenia is about 50% of patients will get grade 3 or 4 neutropenia, and we may have to hold your venetoclax, or we may have to give you, GCSF support. And then TLS, I tell them we have to, hydration and allopurinol, oral hydration, allopurinol, and for some patients we also do IV hydration as well. So there is a bit involved early on, but again, I think because we do a lot of CLL in our practice, it's a bit more streamlined because we kind of do it kind of routinely. But I can certainly understand this limitation in other practices.
Nitin, you've touched on this. The counterpart of venetoclax, if you're not using venetoclax, we rely on BTK inhibitors, and you've mentioned second generation BTK inhibitors, Acalabrutinib or Zanabrutinib. Just like FCR, ibrutinib has also phased out our first generation BTK inhibitors. In your practice, how are you making a decision of Acala versus Zanu? And I know you've touched on this, but if you can reiterate, if you are using Acala, do you use anti-CD20 in all of these patients?
Yeah, so good and great question. So I think there's no easy answer to the first question, Acala versus Zanu, because there's no head-to-head data in the frontline CLL for Acala versus Zanu. The data we have is in the relapsed CLL space, where 2 trials were done. One was Acala versus Zanu, one was, Acala versus ibrutinib, the other one was Zanu versus ibrutinib. Both trials showed that the second generation BTK inhibitor was safer. So Zanu was safer to ibrutinib, Acala was safer to ibrutinib. Not a surprise there. We already kind of had predicted that somewhat from previous studies and phase 1, phase 2 studies. But I think to maybe everyone's surprise, Zanu versus ibrutinib also showed improved progression-free survival in favor of Zanu, but that was not seen with Acala versus ibrutinib. So for the last couple of years, I think in the CLL field, this is a constant debate, why that is, and there are lots of arguments why one trial showed PFS advantage versus not the other. But I don't think we can conclude from that Zanubrutinib is better than Acalabrutinib, because they were directly not compared head to head. So, and there will never be a trial really comparing head to head. So I think with that in mind, in my opinion, both Acalabrutinib and Zanubrutinib are really excellent drugs. They're safer than ibrutinib. And I would say that, it really comes down to clinician preference and what they've used more. I know some of my colleagues who have used Zanubrutinib quite a bit. I know some of my colleagues who have used Acalabrutinib quite a bit. So I don't think there is a right or wrong in the choice of these agents. Both are given twice daily, though Zanu could be given once daily. So, but most of the data is with twice daily of Zanu. So some could argue, I'm going to use once daily drug, so with Zanubrutinib, and that's an advantage. But again, most data with Zanu is twice daily. Acala is always twice daily. But other than that, I think both are, really excellent drugs. So I don't think there's really a strong reason to pick one or the other. In terms of the question about obinutuzumab, so the study which has been looked at was a study, Elevate-TN study, in which there were 2 randomized arms. One is Acala and one is Acala-Obin. So the only difference between the 2 arms is that one arm got Obin for 6 months. Both arms are getting Acala continuous daily for a long time. And to most of our surprise, Acala-Obin continues to maintain a significant PFS advantage over Acala alone, which I don't think any of us has predicted that 6 months of Obin will make a difference 6 years later in terms of the PFS, which it has, the most recent PFS from ASH last year.
Yep.
So now, intriguingly enough, the benefit of Obin was in the non-del17p and non-TP3 patients, with the caveat that only 25 patients with p53 del17p were enrolled. But on that patient, there was no benefit, and that's what I was alluding to before. that Acala benefit was mostly in the non-del17p, non-TP3 patients. So I think that my approach so far up until now has been to use Acala single agent. But that data does makes it intriguing to add obinutuzumab to it. Though I would say from a practical standpoint, one of the reasons patients want a BTK inhibitor is just as easy. It's just a pill. There's nothing else. But then if you say, because they're trying to weigh in between BTK inhibitor versus ven-obin, but then you say, oh, I'm going to give a BTK inhibitor also with obin, then that adds infusion reaction and, as you know, chair time, cost, and all those things. So I think that takes away the ease of BTK inhibitor, adding
Absolutely. Yeah, no, absolutely.
So I think, in my practice, I would say up until now, I have used single agent BTK because that's the reason to use a BTK inhibitor in a way. It's ease. If I'm going to use BTK obin, why not just do ven-obin, unless there is some other issue not to use ven-obin, So, so I think yes, but it's on label. It's an FDA approved label, and I know in the community, and I get referrals where patients are, I think, getting Acala obinutuzumab, which is appropriate. You certainly have an improved PFS, but certainly Acala alone is just logistically just easier to give.
And then, what if the disease progresses after first line here? We have also seen a recent approval of Partibrutinib from last year and recently Lysocell this year.
Right. So, I think in terms of the sequencing of CLL, like one treatment comes after another. Obviously, the standard approach has been most patients have been getting BTK inhibitor as a first line. And when they fail, they get ven as a second line because that's how the development of these drugs occurred. BTK came first, then ven. Obviously, if you're using ven as a first line approach, because ven is a time limited approach, you will finish therapy in 1 year. And let's suppose they progress 3, 4, 5 years later, certainly you can put them on a BTK inhibitor, but you could also potentially put them back on venetoclax. And there is data to that effect, retrospective data right now of ven retreatment. You can retreat with ven because you're not progressing while on ven, you're progressing when you have been off ven for 2, 3, 4 years, so that could be done. I think so. First and second choice will be ven and BTK kind of alternating depending on which you started in general. The issue becomes, you mentioned about Partibrutinib, the issue becomes third line because the first and the second line you probably have used BTK and ven in vice versa combination. The issue becomes so-called what we call double exposed. So patients who have been exposed to a covalent BTK inhibitor, which is ibrutinib, Acala, or Zanu, and have been exposed to venetoclax. So for those group of patients, just in the last, I would say 3-4 months, 2 drugs have been approved. One is Partibrutinib, which was approved last year in December for CLL, which is a third generation BTK inhibitor. It is a non-covalent BTK inhibitor, which does work for patients who have failed ibrutinib, Zanabrutinib, or Acalabrutinib. So it's a BTK inhibitor, but it works for patients who have failed another so-called covalent BTK inhibitor. So that's one option. It's just a pill. And the other option, which just got approved a few weeks ago, is Lysocell, which is a CD19 CAR-T, obviously previously approved for DLBCL and other lymphomas, but now we have an official approval, the first CAR-T approved for CLL, which is Lysocell, which is also approved for the same patient population, so-called double exposed patient population. So I think those agents will become, I think, a third line approach for these patients right now, either Partibrutinib or Lysocell CD19 CAR-T cell therapy. And certainly, I think there are other options. Stem cell transplant, allogeneic stem cell transplant has remained an option which we had moved away from over the years because we have so many new drugs. But I think for patients who have multiple refractory disease, I think that's something to consider as well.
These are exciting times, especially for our patients with so many treatment options available when we're talking about third or fourth line rather. Nitin, thank you so much for covering all this in such a short period. As a community oncologist, these conversations continue to help us in appreciating the current landscape and makes us visit a little more comfortable in managing these toxicities. Thank you so much again, Nitin. For our listeners, let us go over a quick recap. In this discussion with Dr. Nitin Jain from MD Anderson Cancer Center, we have covered the current available options for CLL, deciding between limited treatment with venetoclax or long-term BTK inhibitor is the first key step in treatment management here.
Be it new approvals such as Zanabrutinib or Partibrutinib or CAR-T Lysocell, There's a lot that is happening in this disease state. Our focus here is not only on the approvals, but rather how to manage some of the side effects that come along with each new drug that is available to us. Thank you for tuning in to this episode. Make sure to check out our upcoming discussions on myeloma and myelofibrosis. We are the Oncology Brothers.